prefer to perform the surgery in our university hospital. By examination, it was left complicated cataract with occluded pupil. Left eye visual acuity was PL with good projection. Intraocular pressure was 0 mm mercury for the left eye versus 14 in the right normal eye. It was very difficult to change the mind of the father that the operation cannot be done now. I told the father that we cannot operate on such a hypotenuse globe, otherwise the eye may pass into atrophy. By slit-lamp examination, cornea was clear, anterior chamber was very shallow, no cells or flare, posterior synechial all over 360 degrees. Ultrasound was free. The decision was to postpone the surgery till elevation of intraocular pressure. If intraocular pressure does not rise, the operation will not be performed. We decided also to refer the patient to uveitis specialist to rule out the cause of uveitis. This was the uveitis specialist report, a case of left cataract, query post-trauma, query old parasitic uveitis for steroid support and cataract surgery. Now, how to deal with such a hypotenuse globe? I used to use deflustero eye drops to elevate the intraocular pressure in cases of uveitic hypotony, no financial interest. Defloprednate is a potent new topical corticosteroid that exhibits enhanced penetration, strong efficacy, and comparable to posterior subtenon triamcinolone injection in reducing retinal thickness, but with increased risk of intraocular pressure elevation in high doses. So we want to get benefit of this side effect to elevate the intraocular pressure of our patient. We started with a dose of deflustero eye drops 4 times per day, together with psychoplegia and follow-up after 1 week to see the response and to monitor the dose of steroids accordingly. Gradual elevation of intraocular pressure occurred over the following 2 months with steroid support, from 0 to 3, 5, 10, and 16 mm mercury 2 weeks apart. At this stage, we started to prepare the patient for surgery and reduce the dose of steroids from 4 to 3 times a day. Suddenly, intraocular pressure got elevated to be 30 mm mercury. So, I replaced the topical steroids with topical non-steroidal anti-inflammatory eye drops and added a weak anti-glaucoma eye drops. We continued patient preparation for surgery. The father showed me a previous biometry. I noticed that this biometry was done at the stage of hypotony. IOL power calculation was 30.5 diopters. Biometry is believed to be inaccurate if performed in a hypotenuse eye because hypotony affects both axial lens and K reading measurements. I also performed IOL master for the normal eye to compare IOL calculation in both eyes. There was a marked difference in IOL power calculation between both eyes. IOL power was 22.5 for the right normal eye versus 29.5 diopters in the left affected eye. Biometry was repeated several times for both eyes to be sure from the results. The parents deny any history of previous hyperopia in the left eye. Also, the eye was orthophoric. The eye was not amblyopic before, so the difference in biometry cannot be explained. Can uveitis affect the results of biometry? Searching in literature revealed limited studies on biometry in uveitic patients, but this study concluded that lens thickness and anterior chamber depth in uveitis group can affect the results of biometry. Now we have to prepare the IOL. I decided to implant an IOL power to be near to the normal eye power and not far away from the diseased eye power. So I choose to prepare 24.5 diopter accuracy of single and multi-piece IOL. I advise the patient to visit me the day before the surgery to be sure that everything is stable. Surprisingly, intraocular pressure dropped to 0 again, following reducing the dose of steroids. So I had to postpone the surgery again, return it to the higher dose of steroids and stop the anti-glaucoma medication. I also told the parent that sudden drop of intraocular pressure shortly following reducing the dose of steroids is a bad sign, with guarded prognosis following the surgery, with possibility of post-operative ciliary body shutdown and atrophy. 1 month later, intraocular pressure gradually elevated to reach 16 mm mercury, and we prepared the patient again for surgery on the same dose of steroids. First of all, I tried to perform gentle synechial all over the 360 degrees. Iris hoops was inserted for better visualization. Then I tried to polish the anterior capsule from the deposited iris pigments to prepare for anterior capsular excess. Unfortunately, pigments was tightly adherent to the fibrotic leathery anterior capsule. I started to make an opening in the leathery capsule with the help of MVR blade to start the anterior capsular excess. Every effort should be taken to save the bag as much as we can, because in the bag IOL implantation is mandatory in uveitic patients. Sulcus IOL implantation promotes iris shaping, carrying the risk of recurrent attacks of uveitis with its complications, especially in an already uveitic pediatric patient. I tried to continue the capsular excess cautiously with the help of micro scissors. Taking care not to extend the cuts from the fibrotic capsule to the non-fibrotic peripheral part of the capsule. It will be a very weak point with the risk of sudden extension and loss of the bag during IOL implantation. Now, removal of the fibrotic capsule with vitreous cutter and irrigation aspiration of lens matter. A bulk of fibrous tissue appeared, which was found to be interlenticular, posterior capsular, and extending to the anterior vitreous, trying to remove it with viscous cutter. The fibrotic mass may be the remnants of previous parasiplanitis or parasitic granuloma. In the bag, a Kresoff multi-piece IOL implantation was done, not single piece, because I expected a wide posterior rhexis, as the post-uveitic fibrosis should be removed extensively because it has a high tendency to recur. At this stage of surgery, tight closure of the wound should be performed for vitrectomy to be done under a closed system. Severe hypotony is expected due to the presence of liquefied vitreous. From behind the IOL, cystitome failed to open the posterior capsule. So, MVR blade was helpful to start posterior rhexis. Regular circular posterior capsular rhexis was created together with anterior vitrectomy and cutting the post-uveitic fibrosis. We can notice the rapidly moving waves of the liquefied vitreous in the uveitic patients. Here we can notice the wide posterior capsular rhexis, and we try to remove much of the fibrotic posterior capsule to avoid postoperative membranes or late secondary cataract. Posterior capsular rhexis and anterior vitrectomy was finished. Iris hooks was removed and subconjunctival injection of dexamethasone was done. At the first postoperative day, cornea was cloudy, very high intraocular pressure, no red reflex, so we started extensive anti-glaucoma medication. At the second postoperative day, the child markedly improved with bright red reflex and normal intraocular pressure. OCT macula was done first week postoperatively to exclude uveitic macular edema. OCT was free. At the first postoperative month, sutures was removed, normal intraocular pressure without medication, steroid withdrawal also was done safely, and bright red reflex. At the second postoperative month, the child gained a visual acuity of 6/12 with very acceptable refraction following his strange biometry. At the sixth postoperative month, the child is doing well, no uveitis, normal intraocular pressure, no medication, and stable refraction. Taking home message, take your time to evaluate the patient especially pediatric age group. It is very important to measure the intraocular pressure in cases of traumatic and uveitic cataracts, never to operate upon a hypotenuse globe. Please do biometry for both eyes. In case of traumatic and uveitic cataracts, biometry of the healthy eye will guide you to obtain an accurate refraction for the diseased eye. Thank you.